Hello everyone. Continuing with our case discussion. Today we are going to discuss a very interesting case in microbiology. And as said before, this case discussion will be covering up the entire topic related to that case. And this will be a mild relaxation in between our studies in a productive way. Without any delay, going on into our case. Today we are seeing a case of a mother bringing her 14-year-old son to the pediatrician because the child has experienced flu-like symptoms and conjunctivitis for the past 3 days. The child is pale and febrile at 39.9 degrees Celsius, that is 102.7 degree Fahrenheit, and his respiratory rate is 25 per minute. His buccal mucosa has multiple blue-gray spots and he has a maculopapular rash. His mother states that the rash has started on his face and then spread to his torso. The physician notes that the skin lesions blanch with pressure, and the mother states that her son is usually healthy and has never needed any medications or vaccinations. And we can see this picture. We can see the rashes being present all over the body. Now, we are going to see regarding this case the most likely diagnosis of the boy, the potential differential diagnosis, how will we confirm the diagnosis, and what is the sequelae of this disease, and the appropriate treatment. Now, coming back to the case, we have to actually concentrate on the key points in the case. That is, the patient is actually a pediatric child, that is 14-year-old. And actually I say pediatric because in many texts they tell that till 14 years it is pediatric population. And the child is having flu-like symptoms, conjunctivitis, fever, and blue-gray spots. I think most of you would have picked up the diagnosis by this word, blue-gray spots and maculopapular rash that started in face and then to the trunk, and the lesions blanching with pressure. Now, what is the diagnosis? Yes, it is measles. Now we will be seeing a brief notes of measles. We will be concised only to the exam point of view, and all the exam point of view points will be discussed in this discussion. Measles virus is also called as rubeola virus. It is actually an RNA virus with from genus Morbillivirus and family Paramyxoviridae. The sources are only the cases, that is, it is transmitted from one case to another person, and there is no carrier state for this disease. Reservoir is only humans, no animal reservoirs are there, and transmission is via respiratory route. Incubation period is 10 days and period of communicability is 4 days before and 4 days after onset of rash. Okay, it is actually 4 days before and 4 days after onset of rash. This is actually a previous year question, and so we should actually keep this in mind. And the secondary attack rate is more than 90%, and thus it has high communicability rate. Now, the age of onset is that this is actually a childhood disease, and in developing countries it occurs in children between 6 months to 3 years, and in developed countries or vaccinated population it occurs in more than 5 years children, and also in adults rarely. Immunity: no age is immune if there is no previous immunity. Okay, in this case it was actually said that the boy was not vaccinated or have had any medicines. That is, his mother is telling that his boy is healthy and he has not had any vaccinations before. So this is an important history. And in the measles there is only a single serotype, and so once if you are attacked you have lifelong immunity. Actually before 6 months the children are actually protected by the maternal antibody, and so before 6 months there is no risk of measles. Genotype, there are many genotypes available all around the world. We have to just know that most common globally is B3 genotype, and in India it is most commonly with D8 genotype. Now the manifestation sequence, actually it has an incubation period of 10 days. Then after this 10 days we have the fever. That is, the fever is the first manifestation to be noted, and then after 2 days of fever we have Koplik spots. That is, the mother told the history na, that is the white blue spot with and this spot actually occurs first near the second lower molar and then spreads to the entire buccal mucosa. And after this Koplik spot, after 2 days we have rashes, and this rash is first appearing behind the ears. Actually this is a question. It occurs first behind the ears, then face, arm and trunk. That is, it is cephalocaudal in presentation, and this rashes also fade in the same order, but these rashes are absent in HIV patients. And coming on to the diagnosis, it is done using Viro or H-SLAM cell line, which is recommended by CDC, and this virus has a cytopathic effect, that is Wartin-Finkeldy cells, that is multinucleated giant cells having both intranuclear and intracytoplasmic inclusion bodies. Most of the times we will be remembering this Wartin-Finkeldy cells, but we will not remember whether it is intracellular or intracytoplasmic. Okay, for measles it is both intracellular and intracytoplasmic inclusion bodies. And actually for confirming the diagnosis, which it is not present in this notes, we have to, you please hear this point clearly, to confirm the diagnosis we have to see for the anti-measles IgM in the patient serum. Okay, this IgM actually appears approximately 48 hours after the onset of rash. Okay, this point is actually not in the notes, so please make note of it, that the diagnosis is confirmed by using anti-measles IgM in the patient serum, and it appears approximately 48 hours after the onset of rash. And the complications, if we see, most common complications are otitis media and bronchopneumonia, but rare but most severe is SSP, that is subacute sclerosing panencephalitis. We have to see the question correctly. Most common is otitis media and bronchopneumonia, most severe but rare is SSP. And there are also many other CNS complications, and these CNS complications are fatal within 1 to 3 years of onset, and the mortality rate for the CNS complications is about 10 to 20%. This CNS complications due to measles can be diagnosed by high titer antibodies in the CSF. Now vaccinations. This is also an important part to concentrate in measles, because this will be asked both in community medicine and in medicine also. The vaccinations available are live attenuated vaccines, and the strains used for vaccines are Schwartz strain, that is the most standard strain used in most of the parts of the world. Also we have Edmonston Zagreb strain and Moratin strain. We can see that there is 3 strains as of now, and so it can be asked as all the above except, like that kind of questions we can expect in this. And these vaccines are made from chick embryo cell line, and these vaccines are available as lyophilized forms, and so we have to reconstitute them with distilled water, and after this reconstitution we have to use within 4 hours. This reconstituted vaccine is thermolabile, so we have to store at 20 degrees Celsius. And one dose is actually 0.5 ml subcutaneous. This one dose contains more than 1000 infective viral units. And the time of vaccination is at 9 months along with vitamin A supplementation in routine vaccination. And in case of outbreak, the vaccine should be given at 6 months and the second dose should be given at 9 months. The side effects of this vaccine include mild measles-like illness and toxic shock syndrome due to the contamination of the vaccine vial with Staph aureus toxins. Now, seeing the post-exposure prophylaxis, that is following the exposure to measles, we can take both measles vaccine or the immunoglobulin within 3 days of exposure. This is important, within 3 days. And this immunoglobulin dose is actually 0.25 mg per kg body weight. But we have to note that we should not give this measles vaccine and immunoglobulin at the same time. Okay, if we are taking both, then we have to leave at least a gap of 8 to 12 weeks in between them. And the treatment part, there is no particular treatment, it is only supportive treatment, and the patient who is infected should be kept in isolation. And regarding the eradication, WHO has the eradication strategy of catch up, keep up, follow up. Okay, catch up is that at one time all the children between 9 months to 10 years will be vaccinated irrespective of their immunization. And then after that, every 2 to 4 years, all the children who are more than 9 months, who were born after this catch up campaign, will be followed up and vaccinated. Okay, so this, just you have to keep in mind that the strategies catch up, keep up, and follow up. Okay, thus we have come to the end of the discussion today. I hope I have covered all the important points in measles. And that's all for today's case discussion. And have a good day. Thank you.